We now have about 25 minutes to engage in some questions with our panelists. Again, for those of you who want to submit questions, please use the text box below this webcast, and we will try to get to as many as we can. I'm going to start off with what might seem self-evident from some of the presentations, but I think it's really important because it's so foundational in how we approach the measurement of access today. So I'm going to ask if any of our speakers could comment on whether they believe whether wait times is a sufficient single measure of access to care. That has been used in some settings. So just be curious to go around and to see your reactions to is wait times a sufficient measure by itself of access to care? Anyone want to take that? Looks like, John, you have your hand raised on that. Maybe you want to comment first?
Sure. I mean, it's an important dimension of access to care, how long you have to wait for an appointment. But it's not the most important one. So it should not be the single measure of access to care for veterans, in my opinion.
Yeah. Anyone feel differently that it is adequate or want to endorse what John's saying? Yeah, Hal, go ahead.
Yeah, so, I think it's important. The interval that an individual waits for an appointment is important. I guess to me, the question is the fact that it's looked upon so often as a static metric. It has to be by 7 days. It has to be by 14 days. It has to be by 30 days. So I would add a condition to it. To me, it's what is the appropriate interval that patient for that condition should be seen at, and how close can we come to that? We miss a lot if we put an average of 14 days or a regulatory expectation of 14 days, let's say. I think, how do we move to a place where we tailor what the patient's need is to what we expect the system to give? To me, that's how we might look at wait times and access.
Terrific. Well, thank you. So I'm going to take it that I'm not hearing any endorsement of the idea of using wait times as sufficient as a sole measure. It could certainly be used as part of it with some additional information. I want to turn to that next question. This one seems like it would be directed to you, Dr. Gelberg. First, the questioner endorses with a says, I love the humanism pocket tool. So maybe could you say a little bit about whether this the use of this tool is a required metric in determining access to quality care?
Well, thank you for asking that question. I would love for it to be a required metric for quality of care, for assessing quality of care and access, because without it, you're not going to get the access. People are not going to be wanting to come. The veterans aren't going to be willing to come in for care, especially if they've experienced trauma, if they have complicated backgrounds, if they perceive stigma or discrimination. You can have all the bells and whistles for access, and they're not going to be able to use the care. So we need to create care that veterans want to access.
Great. Now, one of the things that had come up in the presentation that Dr. Agrawal was making toward the end, and I think I heard some statement there that the measurement of access in the virtual world, if you will, the digital world, should perhaps parallel that goes on in the real life world. And I guess I'd like to explore that a little bit more with our panelists. I want to make sure, first of all, I've kind of that summary statement is relatively accurate of what I saw in the presentation, but also maybe ask Dr. Yee if he would agree with that, or if any of our other panelists have opinions as to whether the measurement fundamentally of access to care differs depending on whether we're dealing with the real life actions versus what can happen through digital communication.
So from my perspective, I do think that the modality by which we're providing care to the patient, whether it be telehealth, synchronous, asynchronous, or in person, or a class, probably does need to be tailored in terms of the timing. For example, somewhere earlier today, there was mention of sometimes vets just want to pick up the phone and talk to somebody. When that's the case, people don't want to wait 2 weeks, even if the access standard said 2 weeks. If somebody wants to pick up the phone, we need to reassess what that right time is, right? If somebody simply wants a question answered, how do we have the system adapt so the access to the phone call visit or the phone call might be measured in minutes instead of days? So I do think you have to tailor the modality to the interval between when the request is made and when the person is provided that care.
Great. Dr. Agrawal, do you have a comment you want to make about this?
Yeah, I think I agree with that last comment. So I think, the modality that's chosen really should be a function of what's clinically necessary as well as consistent with patient needs and expectations. I think from a quality standpoint, we should be a little bit modality agnostic about what we are hoping to achieve. So regardless of whether it's synchronous, asynchronous, a video conference, or an in-person encounter, I think we should have consistent outcomes or consistent expectations of what outcomes should be achieved, that we've met the patient's expectation, that we haven't missed important diagnoses or delayed care or produced waste. I think that was the main point I was trying to drive towards, that the choice should be driven by important individual features, but we should place these different access modalities on par with each other as far as our expectations.
That's great. Thank you. I have another question that's come in here, which is the point is raised that how it's about the intersection of access and choice. So the commenter writes, access without choice does not really seem to be access. My experience is there is a little to no choice in provider service, care plan availability, of peer support, alternatives to treatment as usual. And so I guess I'm wondering if any of our speakers would comment on how they think about access and choice as an interaction. And when I turn to you first, Dr. Courtney.
Yeah, so that's a fantastic question. And I think it highlights the contrast I was trying to make between kind of actual access measures and perceived access measures. If looking at a travel distance as an example, an actual access measure would calculate the travel time or travel distance from a patient to the nearest provider. Well, the patient might not want to go to that nearest provider, right? So it's much better to ask people, is traveling to the provider you want or the services you want a burden to you? So I think the focusing on perceptions is a way to allow people, for us to incorporate choice and preferences into these measures of access.
Yeah, Dr. Gelber.
Great question.
Dr. Gelber, do you have a comment on this as well?
Yeah, I think this is a great question. What we're seeing, like in our homeless veterans, that they often, it's timing, and we can provide access, but it has to be around when the veterans are ready for that access, when they're interested in that access, and being very patient-centered around it is being available and accessible when the veteran wants that access. And then the other thing I was thinking about, the prior question about access in the digital world, should it parallel real life? One of the things I'm seeing in, at least, my experiences with our homeless veterans is having mental health care that's digital for many of them is not meeting their needs. And so it may be timely, it may be accessible, but it may not be reaching the veterans' choices. Even one of the veterans said to me, Dr. Gelberg, would you just take your mask off? I want to see your smile, because for 3 months, I haven't seen a doctor's smile. I've been on the phone with my doctor. And that was such a profound just interaction for me on the importance of how in this digital world are we going to be creating access. And I don't think, we all don't think telehealth is going away. It's not just going to be here during the COVID pandemic era. So thinking about how is that digital access, what does it look like in terms of the veterans' preferences?
Yep, that's great. And maybe tied into this, there's another question that comes in asking whether the Veterans Health Administration has worked with tools like GIS to gather and present access data. So this would be information presumably about the location of veterans vis-a-vis the location of resources available to serve them. And I don't know, do any of our panelists have insight or knowledge about this? John, looks like you have your hand up, so maybe you can take that on. Yeah. Oh, John, you might be on mute.
Sorry about that. Yeah, the VA uses GIS all the time to determine what areas of the country veterans have unacceptably long drive times. They use that to decide where to locate community-based outpatient clinics. They also use GIS to determine whether veterans are eligible for community care. So patients often get referred to community care if they're having to drive too long for a certain service, and that gets determined using GIS.
Yeah. Lillian, did you have an additional comment on this?
Yeah, so we have a measure called competing needs for healthcare. And these are needs like for housing, for child support, for caregiver support, for a place to wash up, for a place to get food, for food insecurity, for the dangerousness or the community violence, and these measures, we've been working with GIS, let's say around VA permanent supportive housing or around healthcare facilities or around the veteran's home. Is it a safe area where they can feel that they can leave to be able to access care? Are there other needs met? In the Maslow's hierarchy, are there needs met for community integration, for social integration, for safety enough so that they can access care even when they want it and they need it?
Oh, that's great. Thanks so much. I wanted to raise a question. Dr. Yee, you had presented material on your notion of precise access. I'm wondering, A, do you think it's something that is amenable to the VA population? And I'd also be interested in, because what was interesting in what you described is sort of giving the power of determining appropriateness around the timing to the interaction between, say, the primary care doctor and the specialist. I'm wondering if you have some sense of kind of the reliability around that, and whether does that, on the one hand, make use of the special knowledge that providers have, but on the other hand, introduce a level of discretion that could undermine creating a standard. So maybe two questions there. One is its applicability to the VA and the confidence you have about being able to implement this in a way that will ensure a highly reliable standard.
So the answer to the first question is, I think the VA, because it has used in various forms electronic consultation or dialogue between primary care and specialty care for literally decades. I mean, even when I had VA8s at GLA back in the late 1990s, it was possible to have dialogue with your specialist. And I know that there are VA systems and services now that are extensively using electronic consultation. So I think that the VA would be a very appropriate place to do this. The fact that the VA providers are generally employed physicians on salary reduces the sort of fee-for-service drive for a lot of specialty visits and speed and all of that kind of stuff. So I think the VA is the right place. You know, the question as to whether the dialogue between the primary care provider and specialist does get to something that approximates the right timing, I think depends on that presence of dialogue. So there are some e-consult systems which are unidirectional, primary care to specialist, done. I think in those systems, you could very well worry about whether there was too much control by the specialist. I think that in both the San Francisco model and LA model, you know, which I architected, it was always the case that it was a dialogue. And in fact, in both models, the specialist cannot close the dialogue. It's the primary care provider who has the control. So the goal really is that the two providers become a team thinking about what's best for the patient. And when they do that, I do think that you get to as close an estimate to the right time as you can. And certainly that's better than just saying, do it by 14 days or do it the sooner the better. Great. And we are studying the use of these precision percentages, but that hasn't been published yet.
Yep, great. John, did you have a comment on this as well?
Yeah, I mean, I totally agree with Dr. Yee that, you know, setting these standards, one size fits all, doesn't make any sense whatsoever, and that focusing on the individual needs of the patient is what we should be doing. I think, however, I disagree somewhat with some of the speakers about, you know, trying to measure appropriateness. I think that's a slippery slope. What's appropriate for one veteran versus another is very difficult to measure and would be probably not possible to do in some kind of access metric. So I think it makes more sense to ask the veteran, did you get the care in the timely manner that you needed? I think that simplifies the measurement problem greatly.
Great. Dr. Kirsch, I see you want to bring up a question or a comment.
Thank you so much for that. First, I wanted to address using some of the geographic software tools that that within the Access Office, we oversee access for underserved veterans based on some of the HRSA modeling. And we do use some of that software to be able to help calculate underserved communities, and then specifically have strategies that may be different than someone who lives in a large medical center area and is easily able to get into that medical center or get their care. So we do use that as some of that software around underserved communities with different strategies to address those in rural communities and in underserved communities for a number of other reasons. I also wanted to really comment that I appreciate Dr. Yee, your contribution. I really was involved in e-consult implementation in the VA in 2012 and have published something subsequent, and we continue to think about e-consults. The bi-directional e-consult is really interesting. I know a number of my colleagues from my office are on, and we're probably thinking about how we can take some of that work and move that forward, really about appropriateness and getting the right care at the right time. So I just thank you for calling on me to make a few comments here.
Terrific. Thank you so much for that. We just have a few more minutes here left in this session. I do have a question here in which we're being asked, can we integrate perceived and actual access to develop measures that are available and standard for health systems to adapt and improve? And how do we move towards ideal measures? What would that look like? Using paradigm. The question is, what is the triple or quadruple aim of access measurement? Fundamentally, the questioner is asking, how do we advance? What is the next step for us to move forward? I know this will come up in the next session as well, but I'm wondering if any of our panelists have a thought on what they see as kind of the next natural step for the VA in this regard. And Dr. Fortney, what do you think? I think maybe mute again, sorry.
Sorry about that. I think we probably don't need more committees trying to come up with access metrics. I think what we need is veteran input on this. And the VA does get input from veterans, but what we need is a concerted effort to have veterans decide what dimensions of access are most important to them, how they think they should be measured, whether it's actual or perceived. If it's perceived questions, get them to help write questions or vet questions. I think that's the way the VA should move forward, is focusing this on the veterans and getting them to help us decide what to measure.
Agarwal, NQF, I think, is working on this. Can you give us some sense of that? Yeah.
Sure. Well, I will agree with what John said, although I will have to defend the utility of committees since that is how we do our work. But I think where it comes together, maybe just two comments. First is I think this is a great use case for patient-reported outcomes. I think this is, to get beyond just the experience of access or how patients report on that experience, but really connecting relevant, valid patient and clinical outcomes to access, I think would help that integration. The second point very quickly is I was really intrigued by Cameron's comments at the beginning of the day, where there's a feature of access around provider competency. So imagine a future state in healthcare where there wasn't actually variability in outcomes, in clinical outcomes that could be achieved. But like other industries, we could get to homogeneity in those outcomes. Then the patient experience of access or the patient reported outcome of access is the integration, because they would know in their hearts, they would trust the system that if they got access to services in a way that met their needs, that it was also the ideal set of services with the ideal outcomes clinically and from a value standpoint. That, I think, is the ultimate integration of access and these other aims.
Fantastic. Thank you. All right. Well, we have about a minute or two left. I have one last question here I want to put before the panel, and that is, it's a comment that the commenter says that rather than using something like completed appointment wait times, is a measure like third next available reasonable to consider as a way to try to measure access? What's the role of that kind of measure? I'm wondering what our panelists think of that as a measure. As a way to try to measure access. Is that a useful concept? Any thoughts about that?
I guess I would just say, Andy, the concern with third next available is it does get to a one size fits all based on the system and not the patient's perspective.
Right. Well, that certainly reinforces much of what has been said during this session. I'm going to bring this session to a close. I really just want to thank each of our panelists for tremendous presentations, as well as a lively engagement in this question period. I think you've done an outstanding job of setting up the next session, which will get even deeper into how to move from this concept of access into specific measurements. So thank you very much.